Hello, everyone. Good afternoon. Happy Friday, and welcome to the first on location episode of Dr. Tristan Anaesthesia Tutorials. I am here in the stunningly beautiful Clarence in the Free State. We're here with the family for a long weekend for my dad's 70th birthday and for my brother's 49th birthday. So happy birthday, Dad. Happy birthday, Pops. And happy birthday, Robert. And we wish you both very well. So, guys, I just have to say an incredible thank you. I'm blown away. You have the response has been incredible. I have had feedback from many people in South Africa, but as far as the United Kingdom, the US, Canada, Australia, New Zealand. So as I keep saying, please, I do this for the broader anaesthetic community. I do this for the broader medical community. And I do it because I love it. And I think that there really was a need. So you guys have been amazing so far. I couldn't have had a better start. And I'm really grateful. So the last thing before we head into our next episode is you'll see on all of my show notes and descriptions now there is a disclaimer. I just am going to read it out at the beginning of every episode, just because this channel does involve medical advice, and so I will just briefly read out the disclaimer, and this is just to protect both you and me, guys, from the lawyers. And so welcome to Dr. Tristan Anaesthesia Tutorials. This podcast is designed to educate medical students, anesthesia trainees, and qualified anaesthetists. The objective is to provide up-to-date evidence-based clinical anesthesia teaching and practical experience. Disclaimer and copyright notice for Dr. Tristan Anaesthesia Tutorials podcast. Dr. Tristan Anaesthesia Tutorials is an educational resource intended for the global medical and anesthetic communities. This podcast provides general educational content and is not a substitute for professional educational content, medical advice, diagnosis, or treatment. And then finally, the show is separate from Dr. Tristan Leonard, myself as a person, as a specialist anaesthetist, and is not affiliated with the College of Medicine of South Africa, the College of Anaesthetists, or any university other than for CPD accreditation from August. And I am currently not involved in any examinations with the Colleges of Medicine of South Africa. Copyright 2025. All rights reserved. Okay, so now we've paid the lawyers, guys, and let's get going. So today, in our episode, excuse me if you hear a few hoots and birds and things, we are outside, but I thought it would be nice. So we are going to be talking about considerations in pediatric anesthesia. So here's a nice picture. This is just some educational material I've put together. Basically, there's a book in the UK. The NHS trusts are really good in terms of producing educational material, etc. So Reese Bear has an anaesthetic, which is a nice little cartoon book that helps to explain to them what they could be expecting. So as always, guys, those of you that know me will know that we start off with definitions. So in pediatric anesthesia, a neonate is any child up to 44 weeks post-conception. An infant is 44 weeks post-conception to 1 year of age. A child is 1 year of age to 12 years, and then an adolescent is 13 to 16 years. Those are the important definitions for us, but remember, within child, you would then have a toddler, you would have a prepubescent, a pubescent, and then an adolescent, okay? So there's lots of subsets, but this is what we're going to be talking about when I use these words. And why is pediatric anesthesia for some people challenging and intimidating? Well, there are important anatomical, physiological, pharmacokinetic, pharmacodynamic, and psychological differences. And I'm sure all of you would have heard this saying many, many times before from pediatric anaesthetists, is that a child is not just a small adult, okay? They are their own subset of Homo sapien. And it requires a little bit of extra effort, a little bit of extra thought, a little bit of extra insight. But pediatric anesthesia is not and doesn't have to be scary, guys. It really doesn't. And it also shouldn't be intimidating at all. The amazing thing about kids is that no matter how sick they are so incredibly resilient that I have seen children on death's doorstep, okay? And they were really, really, on the edge, and they survived. And we were incredibly, incredibly surprised. But it keeps happening, and it keeps happening, and it keeps happening. And that's why I find pediatric anesthesia so incredibly rewarding. Touch wood, none of my patients ever die, basically. 1 in 1,000 kind of thing. If that's 1 in 10,000, So it's really good from that point of view. The kids are really sweet. The parents are sweet. But I don't love kids so much that I want to keep them awake and crying for the whole procedure. So pediatric anesthesia is definitely the best of both worlds. So as we move forward, we are going to be looking at the anatomical considerations first. And the most important one, and that's why I put it there, always in our ABCs, is the airway anatomical considerations. So the problem here, as you can see in that image, is that these children have a large head, a short neck, and a prominent occiput, so that when they lie down flat, their neck flexes forward and closes off their airway. I'm sure you've all seen that. And I'm sure you've all seen that if you just put a little bit of a bolster or elevate their shoulders slightly so that the tragus is in line with the nipple, your intubation and bagging efforts become much, much easier. Their tongue is large in relation to their mouth, and especially if you are now considering children with trisomies or congenital abnormalities. Their larynx is higher and more anterior. So remember, an anterior larynx is almost as you imagine as a child lies in front of you. I describe an anterior larynx as I have imagine that this is my infant, okay? And I'm now looking in this plane as I look into the mouth, all right? Remember, just because of the angles as that child's lying, my natural gaze looks down into the hypopharynx and into the esophagus. And that's just a common mistake in all intubations. And so that's why my tip is always, when you intubate, you need to be intubating at arm's length. Because look here, as I put my laryngoscope in, okay, and I lift up, it's far away from me, as you see, if we do it like this, far away. As I look, I'm not looking down anymore, I'm looking anteriorly. And it's even more important in a child, because their larynx, if you imagine that this is the back of the hypopharynx, okay, here on the phone, their larynx is sitting somewhere floating up here. So again, if I'm too close and I look down as in, I can't see the USB stick, okay? I can't see the larynx. So again, you need to bolster them and be distant. And I do a little lean back. It looks quite cool. You do like a little one leg back, you look like a real professional. But there is method in my madness, and it is because of the anterior larynx. They have a long, stiff epiglottis, we've all seen, and there's nothing more irritating when it flops into the way of your view. Their airway, we've always said narrowest at the cricoid. It is still controversial. Is it narrowest at the inlet or the cricoid? I don't think it's that important. The second point is what's really important. They have a smaller trachea and therefore an increased resistance with oedema. So again, if you remember Laplace's law, okay, if you decrease the radius, you exponentially to the power of 4 increase the resistance, okay, that the airway is going to have. So now for you and me, I mean, in an average adult like me, you could probably put a size 9 ET tube in comfortably, okay? Now, in a child, if you're putting in a 3 ET tube, that's telling me you've got a 3 millimeter airway. Now, if you've tried to intubate them 4 times because you've been looking down into the hypopharynx and you haven't been able to see the anterior larynx, then 1 millimeter of edema not only decreases their airway size by a third from 3 to 2 millimeters, it will also quadruple the airway resistance, and kids can't cope with that. And then remember, finally, in the first 28 days of life, infants are predominantly preferential nasal breathers, which is because they need to breathe while they feed. But things like choanal atresia or other congenital abnormalities, or even just a severe infection, a virus or a cold, and blocked nostrils can cause these children to have airway obstruction. So here we can look at a comparison. Tongue, relatively large. Larynx, higher and more anterior, opposite C3 and C2. A U-shaped epiglottis. The hyoid-thyroid separation is very close. So what that means is that the space between the hyoid bone and the thyroid cartilage is small. And remember, that is the space that you're trying to open up with the tip of your laryngoscope blade. Their glottis is more cartilaginous, so it is harder to move around. Their arytenoids are inclined inferiorly. Their vocal cords are differently shaped. Their smallest diameter is at the cricoid, and the shape of the head is the pronounced occiput. So all of this put together tells you that you need to be considerate, especially when we talk anatomical differences. The most important one is the airway. And you should always have a plan A, a plan B, and a plan C for your airway in kids. To be honest, 95% of all the procedures that I do can be done either through holding a mask, through nasal cannula with some sevoflurane sedation, or with an LMA. So I only intubate children in my practice currently for neonates, for example, NECs, tracheoesophageal fistulas, etc. All major surgery and the transplants and my neuro kids. But routine procedures, LMA, hold a mask, nasal cannula. We're just going to run through some other important anatomical differences, things we know. Their skin is much thinner with less subcutaneous fat. They get cold. They have less elastic tissue throughout the body. Their blood vessels are rigid. Their heart chambers are rigid. They have a very large body surface area to weight ratio, and that is because they are have these huge heads, okay? So they lose heat from the head and the body much quicker than you or I would, and most babies are bald, so they don't have the benefit of of hair on their head or a beard. And then practically they're smaller. So we all know how you can sickle and struggle and curse the day that you ever decided to go into pediatric anesthesia when you're struggling with a drip. But so practically it can be a challenge. Much more important though, other than the airway, okay, the airway is critical and that's why I put it first, guys, is the physiological considerations. So we're going to start off from the respiratory system and work our way around the whole body. So they have a limited respiratory reserve, okay? Basically, that just means they have limited energy to carry on respiration in difficult or hard circumstances or more trying circumstances. They have an increased oxygen consumption, starting off at around 6 mils per kilo per minute. That's 6 mils of oxygen per kilogram of body weight per minute that is consumed. Contrast that to an adult at rest who is consuming about 2 to 3 mils of oxygen per kilo per minute. They have what we call horizontal ribs, meaning that they have limited bucket handle effect. So if you guys, again, remember from your anatomy, okay, if we imagine, again, over here, this is now my spinal cord, all right? As you look at a human skeleton, our ribs are not like this, okay? They're not horizontal, okay? like that, they are in this direction, all right? So that when you breathe in, you open up. Okay, excuse the pinky, it's a habit. When you breathe in, down, etc. Now, what are infants having? They're born with, their ribs are sitting here horizontally at baseline. So they can only do this little bit, okay? They don't get the big bucket handle effect that they would get from as an adult, okay? They've got fewer alveoli that are just stiffer in general, so their airway compliance is reduced and their airway resistance is higher. Their work of breathing is higher. Their tidal volumes are roughly 7 mils per kilo, as in adults. There used to be a train of thought that like a 1 or 2 kilogram neonate can't possibly only need 7 mils per kilo volume. It is quite disconcerting. So we used to ventilate them at 10 to 12 mils per kilogram. I think that was more a practical issue with the fact that our ventilators previously couldn't go so low. However, now modern day Draeger and GE ventilators and Watto as well can all deliver 10 mils of tidal volume as the lowest. Okay. And then the last point there is that their minute ventilation is rate dependent. You'll hear that again. So remember, minute ventilation is equal to tidal volume times respiratory rate. They cannot increase their tidal volume, I've told you, because they've got less muscle, as well as that bucket handle issue. So they need to have a high respiratory rate in order to maintain normal minute ventilation and normal oxygenation. So that explains why an apnea or even a reduction in respiratory rate in infants will cause very rapid hypoxia. Remember also that their functional residual capacity is low and can be lower than the closing capacity. What is closing capacity? Closing capacity is the pressure at which airways, small airways, start to close at the end of expiration. Now, what happens in infants and in the elderly and in certain disease states is that your FRC, the lung capacity at which you're living, at which you're taking just normal tidal volume breathing, that drops below the closing capacity so that your small airways are closing every single time you take a breath. And that is what we call the FRC lower than closing capacity, and it leads to hypoxia and atelectasis. They have got more type 2 than type 1 respiratory muscles. Remember, type 2 muscles are there for rapid, fast twitch, rapid breathing. In adults, it's for fight or flight or for exercise. And in infants, they need the rapid twitch because, as we said, they're rate dependent, so they have to breathe fast. However, type 1 muscle, which is what you or I have as adults, that is resistant to fatigue. That's your marathon muscle kind of thing. And so that will means that because they don't have enough type 1 muscle, they get very easily fatigued. That's also, as a practical tip, why I never, ever, let's just be clear on that, okay? It's an important safety tip, I believe. I never, ever leave a child who is under the age of 2 to breathe spontaneously on any airway, even an LMA. The work of breathing for an infant on an LMA, unaided, is incredibly high. And on an ET tube, it's astronomical. So the principle is that any infant, child, and in my opinion, to be honest, any patient who has an airway device in them should have at a minimum CPAP, and that's fine for adults and bigger kids, but at a minimum pressure support, okay, for all airway interventions and airway devices in infants and in small children because they cannot cope. Remember that in these babies, 15% of their entire body oxygen consumption is based on the work of breathing. So their respiratory physiological differences to adults are huge. Remember, for us, breathing is incredibly energy efficient. If you remember the hysteresis curve of compliance on the Frank-Starling curve, I'll throw in an an image of it after the show. You will see that in adults, the energy that is expended during inspiration is captured as potential energy that is then used for expiration. And so our work of breathing is almost energy neutral. It is incredibly efficient. Unfortunately, infants and children are not like this. And then lastly, in the respiratory system, we need to talk about the risk of apnea. Apnea is the cessation of breathing for longer than 10 seconds with no respiratory effort. Hypopnea is a reduction in respiratory effort of 50% or more, but no apnea. And then respiratory obstruction is respiratory effort, but a decrease in airflow. So the risk factors are prematurity, the most important risk factor, general anesthesia with the use of opioids, next, neurological disorders, so children with any brain abnormalities, musculoskeletal, muscular dystrophies, neuromuscular junction issues, any child coming for neurosurgery, and then anemia in any infant of any age up until a year. Anemia is an independent, strong risk factor for apnea. So how do we counter this? Well, I insist in post-operative apnea monitoring, and you should as well. It equals an apnea monitor plus continuous oxygen saturation monitoring. So an apnea monitor is a mat, I'm sure those of you that have children have seen it, that a child lies on. It has a sensor, and an alarm goes off if it detects that the child has stopped breathing for longer than 15 or 30 seconds. That is the gold standard. If that is not available, and those often are not available in hospitals, especially in the state sector, continuous saturation monitoring for 12 hours post-operatively, minimum, is acceptable. All infants, regardless of whether they were premature or not, less than 50 weeks of age, should get apnea monitoring. Okay, so all infants, less than 50 weeks is 2 months. So all infants that are term infants that are 8 weeks old or less should get apnea monitoring for 12 hours post-op. For premature neonates, they should get it for a minimum of 24 hours post-operatively. Now we're going to run into the same issues in the cardiovascular system, guys, with the lack of elastic tissue. So they have a less compliant myocardium, and therefore, again, their cardiac output is rate dependent, because if you remember, cardiac output equals heart rate times stroke volume. This is why they have a very high resting heart rate, because their stroke volume is relatively fixed. So if you look at a 1 kilogram neonate, their stroke volume is roughly fixed at about a maximum of 5 mils. Okay, now that's tiny. That's a teaspoon of water every heartbeat, okay? No matter how fast they increase the heart rate, they can't increase that stroke volume. And remember that at a point, your efficiency tips off, and an increase in heart rate will no longer be beneficial. And we're going to go through that concept when we go through our basic sciences and cardiac physiology. But if you remember that as your heartbeat increases, it has got 2 portions in the beat. It's got systole and diastole, okay? Now, systole is really important because that gets oxygenated blood out of the left ventricle and into the body, okay? So you need a decent, excuse me, I lost my train of thought there. Oh, we're going back now. Okay, sorry. So imagine now that you have this 5 mil stroke volume, okay? The heart rate goes from 140 to 160. The child's bleeding. You're not catching up. Once it gets to about 180, you're going to see then your blood pressure start to drop in the child. Drop in blood pressure, and we'll go through this in neonates, is a late sign, okay? So they're trying to compensate with the heart rate with going up. But as the heart beats so fast, it has no time for diastole. It has no time to relax, suck up a nice big load of blood and push it out. And it's the same thing in adults. So in an adult, once your heart rate gets above about 180 or 160, it becomes inefficient. You no longer increase cardiac output because of the drop off in stroke volume. okay, because of the loss of diastole. And it's the same thing once infants and neonates get above about 200 or 220 if they're premature. So tachycardia is important, but don't just let them beat fast wildly, please. They have a dominant parasympathetic or vagus tone, okay? And I basically have described children as one giant vagus nerve. So if you do anything to them, their first response is bradycardia, and their second response is apnea to anything. If they're hypoxic, if they're acidotic, if they're hypovolemic, if they are have been starved, if they are hypoglycemic, if they have pain, if they have any sort of overzealous induction with large doses of propofol, large doses of opioid, or high concentrations of gas for a long time, they've got an immature baroreceptor reflex. So in response to a drop in blood pressure caused by the vasodilation of the anesthetic, or in response to the drop in blood pressure from the bradycardia as a vagal tone response to any of these stresses, these children cannot increase their heart rate and hence cannot increase their cardiac output. And they also are not like adults, whereby if it's cold or we are hypovolemic, etc., we have what's called the stressed and unstressed volume. So if you remember, the stressed volume is the volume of blood that is in your central circulation actually doing the work, and your unstressed volume is the volume of blood that is sitting in your splanchnic bed and in your muscles and peripheries that's not doing much work. We can constrict our unstressed volume and push all of it, about 2 liters of blood, almost immediately into our stressed volume. Children don't have the ability to do that. They have lower endogenous catecholamine manufacture and release, and they have a poorer response to the catecholamines that we administer. I would strongly encourage, if you're administering catecholamines, to give these children a dose of hydrocortisone, 1 to 2 milligrams per kilogram, as well as make sure that their ionized calcium on the blood gas is above 1.2 at all times. They have lower calcium stores. You need calcium to constrict, vasoconstrict. You need calcium to constrict your alveoli. You need calcium to beat your heart. So they're very vulnerable to the calcium channel blocking effects of volatiles. And they have a very high resting cardiac output. Let's talk about the fetal circulation quickly, but this is a topic for another day. In utero, if you remember, we have a very high pulmonary vascular resistance because the lungs are shriveled. So we have no blood going to the lungs. At birth, the child breathes and you get a drop in peripheral vascular resistance due to hypoxic pulmonary vasoconstriction and the presence of oxygen causing vasodilation in the lungs. Removal of the placenta, this very low resistance bed, you increase SVR dramatically, and the children transition to the adult circulation. Higher systemic vascular resistance and lower pulmonary vascular resistance causes the ductus arteriosus and the foramen ovale to close. Now, there are certain situations where you get risk of return to fetal circulation, okay? And this is in instances of hypoxia, acidosis, hypercarbia, and significant peripheral vasodilation and hypotension. So now, what could cause that? That can be caused by pretty much everything that can go wrong at the beginning of any and every anesthetic. So let me explain it to you. When you have a neonate or an infant, okay, and they are in the first 28 days of life, but at the highest risk is if they are premature, and if they are in the first 2 weeks of life. If they then come to theatre and you induce them, these are unfortunately the children who have got the highest risk of laryngospasm and bronchospasm. So any difficulties with their airways in terms of laryngospasm or bronchospasm on induction, or if they become hypoxic because you struggle to tube them because it's a premature neonate with an abnormal airway or a very anterior larynx, if they become hypoxic, acidotic, hypercarbic, or if they become too hypotensive, if you overdose them on your anesthetic, what happens is that they can then return to the fetal circulation. I'm sorry, guys, I did move inside. It's getting a little bit cold in Clarence. So we're describing the return to fetal circulation. And basically what that is that you have a sudden increase in peripheral vascular resistance and a drop in systemic vascular resistance. So your pressure gradients have completely flipped. Remember, in utero, we've got high pulmonary, low systemic. At birth, after the first breath, we have high systemic vascular resistance, low pulmonary vascular resistance. Now we've run into problems, or the child is septic and acidotic and is bleeding or is losing fluids, and the PVR starts to go up and up and up. You then get a risk of returning to fetal circulation by reopening the foramen ovale and blood going from the right atrium to the left atrium, which, as we know, is a cyanotic right to left shunt. And by the same token, you can reopen the ductus arteriosus, and that can also cause a significant left to right shunt. Let's just look at some normal values for children, and it's something just to keep in mind. Premature neonates will sit at a heart rate anywhere from around 120 to 170, with blood pressures of low as 40 being acceptable. And once you get to the age of 14, basically their blood pressures should be that of an adult. So it's hard to know the correct blood pressure for children of every age. However, their heart rate, their oxygen saturation, their blood glucose, their pH, their lactate, all of those things are much more important measures of a child's cardiovascular status than their blood pressure. Remember, these kids have not lived and picked up bad habits like smoking and drinking and stress and caffeine and drugs and alcohol and all of that. So they've got normal, very soft, pliable capillary beds. So they can perfuse their organs at the end organ capillary bed at a much, much lower pressure than an adult can. Blood volume is something that you need to keep in mind, and I want you to remember this forever. A preterm neonate has probably no more than 100 mils per kilo of blood in their whole body. What does that mean? That means that a 1 kilogram neonate has exactly 1/5 of a Valpray bottle of water in their whole body. And so 5 moles of blood is a 5% blood loss. That is the equivalent of me losing 250 mils of blood. So bleeding is a critical issue. You need to have blood for any infant and any neonate. You have to have blood and FFP in theatre from the beginning for any major surgery or any surgery other than very minor. Let's just run through the rest, guys. The renal system, they have a reduced GFR, reduced renal blood flow. Their tubular function is very immature, so they cannot filter their urine as well as we can, and they cannot get rid of drugs as well as we can. They cannot concentrate their urine, so they don't insert aquaporins in the distal convoluted tubule under the influence of ADH, like we do as adults. And so therefore they produce large amounts of dilute urine. I'm sure parents have always wondered, why does my kid go through 20 nappies a day? Well, it's this. They've got immature tubular function, and they have got, they cannot concentrate their urine because of a lack of ADH. They get dehydrated and fluid overloaded very easily. They handle sodium poorly, and they handle drugs poorly up to 2 years of age. In premature neonates, it's even more of an issue. Their creat clearance is decreased, their sodium retention is impaired, they excrete glucose and so they become hypoglycemic. They can't reabsorb bicarb as well as an adult or an infant, so they then become acidotic. Again, they can't dilute or concentrate the urine as needed according to the plasma osmolality like we would, and so they are at risk of dehydration, and it requires meticulous attention to fluids. The liver has got incomplete functional maturity. Drug enzymes are developed but not yet induced. They've got impaired drug handling and decreased plasma proteins and lower glycogen stores, putting them at higher risk for hypoglycemia. So who is at risk for neonatal hypoglycemia? Well, it is most commonly in premature infants under the age of 32 weeks post-conceptual age, but children who are small for gestational age, children who are septic or who are born to septic mothers, children who are NPO for surgery or due to abdominal abnormalities, and children of diabetic mothers because they've been swimming in glucose for 40 weeks, and then they come, and so they've got a lot of insulin stores. They come out and they have a normal glucose load, but lots of insulin. So it's something to keep in mind. When you check the sugar, you should always check it in theatre after induction with the blood from the drip. I replace at below 3 only, and I use 1 ml per kilogram of 10% dextrose water to get the sugar above 3.5, and then I run a maintenance of 1 to 2% dextrose in my crystalloid fluid that I'm running for the surgery. So guys, this is just a reminder of the oxygen hemoglobin saturation curve and factors that affect the affinity that hemoglobin has with oxygen. And the important ones for us here is fetal hemoglobin. So as you have more fetal hemoglobin, your curve shifts to the left. That means that you hold onto oxygen more tightly in low oxygen environments. So look here. At birth, they have almost 90% fetal hemoglobin, which is because they've been growing up in a placenta environment where the maximum PO2 they've ever been exposed to is probably about 60 millimeters of mercury. So at birth, a normal HbE is around 20 because they have so much fetal hemoglobin. Then remember that there is physiological anemia that occurs in all infants between 3 and 6 months. And this is an issue because this is often the time that these kids come for their surgeries. You know, so the circumcisions, the hernias, the eye issues, etc. Because we don't want to take kids to theatre for elective surgery in the first 3 months. But they're all coming to theatre between 3 and 6 months, and we're not checking hemoglobins. And so just keep that in mind because they could be a little bit anemic. And remember, that could be an independent risk factor for apnea. They have decreased oxygen offloading because this fetal hemoglobin holds onto it so well. They need a higher hemoglobin then, okay? Because they've got lots of oxygen and lots of hemoglobin, but the fetal hemoglobin doesn't release it as well. Their curve shifts rightward as their adult hemoglobin takes over by 3 months, and their levels of 2,3-DPG increase to normal, and that takes 3 months. Their vitamin K dependent clotting factors are factors 2, 7, 9, and 10, and those are deficient at birth, and they have immature platelet function. Our transfusion guidelines, okay, now this we will come to in more detail, but it's roughly no more than 15% of their circulating volume. We've spoken about thermoregulation. They have significant heat loss during anesthesia, and it's mostly radiation heat loss into the environment. And non-shivering thermogenesis is inhibited by general anesthesia. I'm not going to explain non-shivering thermogenesis to you today. It will come in our talk on the premature neonate. So remember, guys, if they're hypothermic, they get respiratory depression and apnea. They become acidotic. Their cardiac output drops. Their drugs are not metabolized, and so they have an increased drug duration of action as well as side effects. They have decreased platelet function, and they're an increased susceptibility to infection. And so therefore, for any infant, the optimal theater temperature is 24 degrees, and for children up until the age of 8, the optimum temperature is 22 degrees. We must pre-warm the bed. We must use a hot dog, ortho wool, plastic wrapping, and warm fluids. In terms of the GRT, infants don't actually have acidic pH in their stomach at birth. It takes 2 days of life outside the uterus before that happens. Their swallowing is poor, making them at high risk for aspiration and gastroesophageal reflux disease. The central nervous system, guys, remember that old school neonatologists used to say that premature infants don't feel pain. We know that is definitely not true. They have fully developed pain pathways. They have a poorly formed blood-brain barrier, so drugs cross easily into the brain, hence the risk of apneas. They have impaired hypoxic and hypercarbic respiratory drives, so they don't respond to hypoxia or carbon dioxide. They've got fragile intracerebral vessels, so they're very prone to intraventricular hemorrhage. And I'm sure you've all seen IVH grade 1, 2, 3, 4, and 5 in premature neonates in your practice. Risk factors for intraventricular hemorrhage is hypoxia, hypercarbia, hyponatremia, anemia, awake airway manipulation or inadequate depth of anesthesia when intubating, and wild fluctuations in blood pressure. And we'll go through intraventricular hemorrhage when we talk about the premature neonate. Pharmacologically, guys, just some quick definitions. Pharmacokinetics is the absorption, distribution, metabolism, and elimination of drugs. Dynamics is just the effect of the drug on the body. So, orally, their oral absorption of drugs is probably increased because they have delayed gastric emptying. IMI is not favored for children due to the pain, as well as the fact that it has a very variable blood supply, and so it has an unpredictable onset, duration of action, and side effects. Rectal absorption is also erratic and can bypass first-pass metabolism. Volatiles in infants are absorbed and eliminated more rapidly. They have a reduced tissue gas and blood gas solubility. And because they've got such a high cardiac output, induction in these children does take longer, because if you imagine, and we'll do this when we talk volatiles, anesthesia with volatiles, going to sleep, is dependent on one thing and one thing only: the partial pressure of dissolved volatile in the blood. Okay? So if I've got SIVO coming in and I've got a torrent of cardiac output going, it takes that SIVO and whisks it away and dilutes it in the whole body. And so you never build up a high enough partial pressure. And so therefore, in neonates and infants, gas inductions take longer. And it's one of the same reasons why the MAC is inversely related to age. So as their age increases, they need less volatile. Let's just quickly go through problems with drug distribution. Infants have got reduced plasma protein, therefore increased free fractions of drugs. They've got lower albumin, so therefore reduced protein binding. Lower alpha-1 acid glycoprotein, and that's, remember, a major binding protein for local anesthetics and opioids. And that is why neonates and infants are so highly susceptible to local anesthetic toxicity, because they have got very low stores of alpha-1 acid glycoprotein. They've got an increase in total body water, extracellular fluid, and blood volume, and so therefore the volume of distribution of water-soluble drugs in infants and neonates is increased. They also have a reduced muscle and fat stores and a reduced reservoir for drugs, and that immature blood-brain barrier, meaning that more drugs and larger amounts of drugs can get into their brains. In terms of metabolism of drugs, we've said immature hepatic function, reduced hepatic blood flow. Their phase 1 metabolism, remember phase 1 metabolism is your cytochrome P450. It can take up to 5 years to reach full maturity. And their phase 2 reactions, which remember is your conjugation reaction, that is where a drug metabolite is combined with something to make it water soluble. That, is only mature after 3 months. And so therefore, because of both of those reasons, they have got an increased half-life, both alpha and beta half-life. And then excretion, reduced renal function, immature tubular function, decreased GFR. Pharmacodynamically, as we've said with volatiles, the MAC falls with age. So if you look at this graph over here, MAC is highest in the youngest, MAC is highest in the youngest, okay? And that's because of that high cardiac output that I told you about. Induction agents, propofol, you need a higher induction dose because they've got a greater volume of distribution, okay? And they have a greater clearance of the volatile. It is not advised to use long-term propofol sedation because they are at high risk for propofol infusion syndrome. In terms of muscle relaxants, remember, these kids have immature neuromuscular junctions, lower acetylcholine reserves, and so they have what we call a myasthenic response to neuromuscular blockers. A myasthenic response just means they behave as a myasthenia gravis would, which means they become very, very weak for a very long time with muscle relaxants compared to adults. Remember with succinylcholine or succinylmethonium, they're resistant to its effect, so they need a higher initial dose, but they are at very, very high risk for the bradycardia, the hyperkalemia, and all of those side effects. So I have not used scoline in a child in 12 years. Non-depolarizers, they are also sensitive. Remember, I told you in terms of their physiology, they don't have a lot of the nice, strong, marathon breathing type 1 muscles. So be careful that you don't overdose these kids. Always, always, always err on the side of underdosing their muscle relaxant. Always, always, always make sure that they are fully reversed using a nerve stimulator. And remember now, with Sugamidex, make sure that you use a good enough dose of Sugamidex so that you don't get any post-operative residual curarization. Morphine, they need a higher dose actually because they have a larger volume of distribution, okay? Fentanyl is well tolerated and its pharmacokinetics as a short-acting opioid are the same in children and in adults. Local anesthetics, as I've told you, they've got a real risk of toxicity because they have this low alpha-1 glycoprotein, so more of their local anesthetic is free to float around and cause problems, and they've got an immature blood-brain barrier, so the local anesthetic that is free, swimming, more likely to get in the brain and cause local anesthetic toxicity. And then finally, guys, just briefly on their psychology, infants under around 6 months of age that haven't been hospitalized chronically generally do not have separation anxiety. Children from 6 months to 4 years are the most upset by separation, and these are the least predictable of our kids that come, and these are the ones that can go a bit wild. Parental presence in theatre is ideal and encouraged unless the anxious parent is making the situation worse. I develop rapport with the children. I play a game. I tell them they're a dragon. If for the MRI, I tell them they're going to sleep in my spaceship and they're going to ride to Mars. I tell them to breathe the smoke. All of those things. Your preoperative visit in peds is incredibly important. And I am in private, guys. I'm super busy. I know how it works. But kids are not the type that you, especially anxious children, you need to establish rapport in the ward before they come to theatre and they get stressed out. So practically, guys, develop rapport, address their questions. If the child is old enough, I always speak to the child first and ask the child questions first before speaking to the adult, and that immediately establishes for the child that I am this doctor is here for them and no one else. Full history, full examination, all of these things we're going to go through intraoperatively, post-operatively, analgesia, awake extubation. These are all topics for our pediatric anesthesia series. Remember that they've got a risk of emergence delirium. We want to get them out of the hospital as soon as possible. And so, guys, in conclusion, children are not small adults, okay? We need to be aware of their differences and unique challenges. It can be stressful, but it's incredibly rewarding. I love doing pediatric anesthesia. I find it incredibly fulfilling. Incredibly stressful sometimes, but as I said, those kids are so resilient. And I get to work with some amazing pediatric surgeons. So I just want to send a shout out to those. Dr. Claire Cullen, pediatric ophthalmologist. Dr. Charles Carapina, brilliant pediatric surgeon. Professor Jerome Loveland, phenomenal pediatric transplant surgeon. And the MRI team at Park Lane Hospital, where we do my peds MRI lists. All of you, mad respect for what you do. I love how well we all work together for the best of kids. And I'm hopefully soon going to be doing some pediatric cath lab cases. So I'll keep you guys updated about that. Okay, guys, so you won't hear from me again for the rest of the weekend once this gets posted. Like, subscribe, and share far and wide. Give me comments, feedback. I really appreciate it. Have a great weekend. And thank you so much for watching and listening. Please, down in the comments, like, share, subscribe. And watch all of my other videos up here and up there. Thank you.